a lengthy session.
This
Actually,
meeting is
myself,
being recorded.
Priya, I will be covering some aspects of the remaining part of the gastrointestinal system and hepatology. Dr. Jasmine will be joining, and she'll be covering the rest of respiratory system, and we'll be also covering some of cardiovascular. Okay, hope all of you pay attention and benefit the most out of it. So I'll quickly go into the topics. So first I'll be discussing on acalculous cholecystitis, stress ulcer prophylaxis. So acalculous cholecystitis. So cholecystitis, we all know it is due to gallbladder stones, acute inflammation of the gallbladder due to stones present, gallbladder outlet obstruction or either a cystic duct, a stone in the cystic duct or in the gallbladder. Acalculous cholecystitis is something that does not happen due to a mechanical blockage of the gallbladder. So it is mainly due to hypokinesis of the gallbladder wall, which results in not incomplete emptying or retention of the gallbladder content, which forms a hyperdense content or a sludge. Okay, this is a form of cholecystitis caused by dysfunction or hypokinesis of the gallbladder emptying. So this usually occurs insidiously. It is a life-threatening disorder. It can result in perforation and necrosis also. When we look at to the epidemiology, it is almost 10% of acute cholecystitis and most common in male. Okay, more likely to develop acute cholecystitis after surgery and increased rates in immunocompromised and patients with retroviral illness. So what is the pathophysiology? It is mainly due to bile stasis, increased lithogenicity, so increased bile viscosity due to fever. So we can look into all of these precipitating factors, dehydration, shock, sepsis, all these conditions will lead to a kind of ischemia to, or decreased blood supply to the gallbladder wall. So there is, and also absence of prolonged oral feeding can result in absence of cholecystokinin induced gallbladder contraction. So this is the main mechanism. And thereby there is microvascular occlusion in the blood vessels supplying the gallbladder and hypercoagulability. Microthrombus can occur. So that is the main mechanism or pathophysiology. Risk factors when we look into diabetes, HIV, any patient in ICU, shock, on mechanical ventilation, sepsis, drastic weight loss, especially patients who are on TPN, burns, any vascular disease, prolonged periods of starving. So these are the main risk factors for acalculous cholecystitis. So I already talked about the pathophysiology. So use of vasopressors is another concern or is another mechanism. So use of vasopressors decreases blood flow, gallbladder wall ischemia, thicken gallbladder wall, which later becomes gangrenous. Okay, so all these factors, volume depletion will result in increased bile viscosity and highly concentrated bile salts. Prolonged starvation can cause absence of cholecystokinin-induced gallbladder contraction that will result in bile stasis, distension of gallbladder. Okay, so what are the clinical features that the patient can? Any patient who's been on ICU with some new onset fever, you will have to make sure you'll have to do a POCUS and see if the gallbladder is distended or not. So that is one thing you will have to remember. So not all patients are going to be awake and conscious and complain of abdominal pain and elicit a right hypochondrial tenderness. So it requires a high degree of suspicion in the ICU. Okay, so if the patient is conscious, right upper abdominal quadrant pain, high bilirubin, cholestatic pattern, that is ALP and GGT will be elevated, fever, right-sided pleural effusion, patient can become hemodynamically unstable also. So what are the pathogens that you need to consider while starting your antibiotics? So E. coli and Enterococcus, two main important organisms, along with Klebsiella proteus and bacteroids. So investigations, abdominal ultrasound is the usual modality that we do at the bedside. And if not, abdominal CT. Okay, always send in blood cultures. So radiological features, there will be gallbladder distension over the gallbladder distension will be there, wall thickening more than 4 millimeter, pericholecystic fluid, and intramural gas can also be appreciated. The three main features would be gallbladder distension, wall thickening, pericholecystic fluid. Okay, intramural gas can be appreciated if there is a gangrenous or necrotic features. Okay, and sometimes if the gallbladder is already ruptured, there will be a free wall and fluid collection in the gallbladder fossa. Okay, a sloughed mucosa, and then inside you will be able to appreciate the hyperdense bile sludge. So other most important investigation that can be done, but normally it's not available in every place is but you'll have to theoretically know this is the HIDA scan. So what is the HIDA scan? That is technetium labeled hepatic immunodiacetic acid scan. Okay. The technetium labeled dye is injected into the is injected IV, and the presence of isotope is not detected in the gallbladder after 4 hours. So there must be some sort of obstruction. So this actually denotes the absence of gallbladder contraction. So this HIDA scan is important is one another important investigation that can be done. So how will you manage these patients? So appropriate hydration, send out blood cultures, start antibiotics, and then uh, what you can do is you should always involve a surgeon, or you should attempt to, if the gallbladder distension and the ALP is rising, patient is becoming unstable, then you should consider drainage. So which modality is better? If the patient is clinically stable to undergo a cholecystectomy, either open or laparoscopic, you should consider that. Patient who are unstable and unstable patients, you can consider a percutaneous cholecystostomy drainage of the gallbladder by a interventional radiologist. Other than that, the other option would be stent placement through ERCP, which can help decompress the gallbladder. So these are the various modalities of approaching acalculous cholecystitis. Complications that can occur are GB rupture, peritonitis, and septic shock. So that is about acalculous cholecystitis. Next topic we will be looking into. So almost all GI hypoperfusion, okay, and volume deplete. There will be increased acid production as well, okay, because of stress. So 75% of the critically ill patients who do not receive stress ulcer prophylaxis will develop ulceration. So what are the three categories of patients? Three categories of stress ulcers. So category 1, stress ulceration with occult bleeding. So with occult bleeding, fecal sample will be positive for the react positive test. So this test detects the presence of occult blood. So the incidence is almost up to 50% can have a occult bleeding. So with overt gastrointestinal bleeding, that is visible, that is clinically visible bleeding, hematemesis or bloody nasogastric tube aspirate or melena. So that can be there in almost up to 8.5% of the patients. So with clinically important gastrointestinal bleeding is something that we are more worried about. So what is considered clinically important? That is overt gastrointestinal bleeding plus one or more of the following. So there will be a visible clinical bleed along with one or more of the following within 24 hours. So either a decrease in the systolic or the mean arterial pressure or a diastolic pressure of more than 20, orthostatic hypotension, that is systolic blood pressure more than 10, or postural tachycardia. So your drop in systolic blood pressure from supine to upright position. So it will be more than 10, postural tachycardia, hemoglobin drop more than 2, and requirement of 2 units of Paxils and need for vasopressors. So these are the three categories of stress ulcers. Who are the patients who need stress ulcer prophylaxis? They categorize into major and minor risk factors. So any patient who is on mechanical ventilation more than 48 hours, including extracorporeal life support. So not all patients in positive pressure ventilation more than 48 hours need, if you have already started the patient on enteral feed. Okay. So positive pressure ventilation more than 48 hours without any enteral feeding or any extracorporeal life support like dialysis or ECMO. So that, and coagulopathy, platelet count less than 50,000, INR more than 1.5, APTT more than 2 times normal. A history of gastrointestinal ulceration or bleeding in the past year. History of any traumatic brain injury or spinal cord injury, burns. So these are the major risk factors, and burns more than 35% of the body surface area. Minor risk factors is sepsis, ICU stay more than 1 week, GI bleed more than 6 days, any glucocorticoid therapy more than 250 milligrams of hydrocortisone or equivalent, use of antiplatelet or NICDs, hepatic failure on renal replacement therapy or any renal failure, peptic ulcer disease, extracorporeal life support, and any organ transplantation. So these are minor risk factors. If any of the two minor criteria are present, that is an indication for stress ulcer prophylaxis. So we looked into the pathophysiology. Most of the time it's not known. Hypovolemia, pro-inflammatory state. So all those things will decrease the splanchnic perfusion. And also use of vasopressors is another concern. So because of this, there is reduced bicarbonate secretion, increased acid back diffusion, decreased gut motility as well, decreased splanchnic blood flow, which results in ulceration. So what are the agents that can be used? Proton pump inhibitors, H2 receptor blockers, sucralfate, and antacids. Sucralfate is something that is going to coat the ulcer, or it is just going to be a barrier. It is not going to neutralize the pH. So you should remember this is not going to be effective. Antacids, aluminum hydroxide and magnesium hydroxide, 10 to 20 ml 4 times a day. So that is also not going to be effective. Okay, it can help in increasing the gastric pH to more than 5. So normally it's around 3.5. So if it can increase it, but the effect is not going to be sufficient enough, or the studies have not shown any kind of great benefit with the antacids. So next is ranitidine, 150 milligram twice a day. Pantoprazole is something what we normally use, 40 milligram uh, per day. So either oral or IV. So what are the concerns with the different agents? The proton pump inhibitors are considered to be more effective agents, but the problems with the proton pump inhibitors are risk of nosocomial infection and C. diff. Okay, and the problem with histamine receptor antagonists are it is more safer, but it is not proven to be so much efficient as the proton pump inhibitors. Sucralfate acts as a protective barrier. It does not suppress acid. Okay, it does not suppress the acid. So infectious complications more with PPI. So we already saw pneumonia, Clostridium difficile, and other hospital-acquired infection because of alterations in the gut flora due to gastric acid suppression. So also it affects the nutritional aspects like malnutrition due to decreased absorption of magnesium, calcium, vitamin B12, osteoporosis can be there, and other electrolyte imbalances. So what does the guidelines say? So indications, we have looked into major and minor criteria. So if the indications are there, you need to start on stress ulcer prophylaxis. Preferred agents, proton pump inhibitors, if you're concerned about the infections and other side effects. H2 receptor antagonists are reasonable alternatives. How long you should continue? As long as the risk factor exists. Okay. And infection risk management, yes, if the patient has any infections, you will have to manage it accordingly and consider stopping the inciting agent. Complications, infections, electrolyte, nutrition deficiencies. So these are the things about stress ulcer prophylaxis. So what does the study say? So there are two studies, the sub ICU study and the peptic trial. So both the studies have shown that proton pump inhibitors are kind of effective in controlling GI bleed in the patients, and the infectious complications, there is no increase in incidence of infectious complications. The composite endpoint of nosocomial pneumonia or the C. diff infection between PPI and placebo is almost the same. There is no increase in the incidence. So these are the two trials. Also, any reason these related patients in the ICU. So the agents of choice is going to be proton pump inhibitors. So next topic we'll be discussing is the short bowel syndrome. So what is short bowel syndrome? It is a clinical syndrome resulting from loss of intestinal length due to a disease or a surgical reduction leading to gut function reduction below the minimum required. So there's a loss of length of the gut, which can result in a water deficit like volume depletion, macronutrient deficiency, as well as electrolyte abnormalities. So this is the definition of short bowel syndrome. So normal bowel length, small bowel length is approximately 275 to 850 centimeters. In adults, if it is less than 180 to 200 centimeters, remaining small bubble. If it is less than this, there is a high risk of malabsorption resulting in nutritional deficiency, electrolyte abnormality, and fluid deficit. So that is short bowel syndrome. The core problem is because of decrease in the intestinal absorptive surface and rapid transit. Okay, and for if you're talking about a pediatric patient, it is less than 25% of the small bowel for the gestational age. So this is the definition. So what is intestinal failure? So intestinal failure is not same as short bowel syndrome. It is mentioned specifically to refer the need for intravenous supplement. That is, it is the gut is not efficient at all. So there is a need for the intravenous supplement, parenteral nutrition, to maintain the health and growth. So this is intestinal failure. Okay. So this, because of this, the patient has a growth defect and very inappropriate gut function and requiring a need for parenteral nutrition, that is intestinal failure. So what is the etiology? Common in adults is Crohn's, acute mesenteric. Yesterday we saw acute mesenteric ischemia, which can result in, if SMA thrombus is there and the bowel goes into a gangrene, you'll have to excise a large portion of the bowel. So the remaining part, if it's less than 275 or 850, the patient can end up in short bowel syndrome. So radiation enteritis, post-surgical adhesions, and any post-operative complications. So in children, the most common complications being volvulus, intestinal malformations, necrotizing enterocolitis. So these are the etiological factors. So normal fluid absorption. Approximately 9 liters happen in the bowel. Okay, so this much absorption of fluid happens through the small bowel daily. On an average, 7 liters in the small bowel and 2 liters in the large bowel. And where are the nutrients absorbed? Approximately in the jejunum, first 100 centimeters of the jejunum, most of the nutrients are absorbed. And last 100 centimeters of the ileum, vitamin B12, bile salts are absorbed. Magnesium is absorbed in the terminal ileum and proximal colon. So these are the places. The initial 100 centimeters of jejunum, last 100 centimeters of ileum. So these are most important points. And the impact of resection will be along with fluid, electrolyte, the major nutritional deficiencies will happen. So, what are the phases of short bowel syndrome? These are the three phases. Acute phase in the first 3 to 4 weeks, and next happens the adaptation phase in the 1 or 2 years, followed by a maintenance phase. So the acute phase is characterized by severe metabolic derangement, intestinal fluid loss. So there will be hypersecretion due to lack of inhibition by hormones. There will be severe dehydration, metabolic derangement, acid-base abnormalities, electrolyte deficiencies, that is in acute phase. Next comes the adaptation phase, which involves the remaining small bowel increases the absorptive surface gradually and slow intestinal transit happens. The intestine tries to move slowly. The motility decreases. So why there can be some amount of absorption that can take place. So this promotes the absorption of nutrients, biliary secretions, and ileal and colonic hormones also. So this is kind of a compensatory mechanism that the intestine tries to do. And reversibility of chronic intestinal failure is more likely with the greater residual bowel length. It all depends, the reversibility depends on the bowel length only, and the presence of ileocecal valve or colon. Okay, the length of the colon or the length of the intestine along with the presence of ileocecal valve. So if the valve is intact and the jejunal length is more than 35 centimeters, reversibility is more likely. If the colonic length is more than 60 centimeters and end jejunostomy, if the length is more than, so these numbers, if possible, you can remember, but just remember that the length along with the intact ileocecal valve, this is an important factor to determine the reversibility of chronic intestinal failure. So next comes the maintenance phase. The maintenance phase happens 2 years later. So mainly the patient should have the diet supplements like oral, intramuscular nutrients, parenteral nutrients. So all the nutritional supplementation should be provided in the maintenance phase. So what are the symptoms? Symptoms of malabsorption. Okay, malabsorption, malnutrition, weight loss, chronic diarrhea, high output fistula, steatoria, because steatoria, dehydration, electrolyte imbalances, severe hyponatremia, hypokalemia. So all electrolytes can be abnormal. Then vitamin deficiencies like A, D, E, K, so all B12, everything will be deficient if the terminal ileum is resected. So potential findings will be hyper secretion of gastric hypersecretion. There will be abdominal cramping as well. So complications. So what are the complications with associated with short bowel syndrome? One is D-lactic acidosis, nephrolithiasis, cholelithiasis, and metabolic bone disease. So these are the specific complications. D-lactic acidosis occurs because of fermentation of carbs by colonic microbacteria. The patient can have slurred speech, ataxia, altered mental status, and psychosis. Nephrolithiasis because calcium oxalate stones are produced. Cholelithiasis if the bowel length is less than 180 centimeters, and metabolic bone disease because vitamin D is not going to be absorbed. So there is another complication, important complication, intestinal failure associated liver disease. So this is because of long-term supplementation with parenteral nutrition. So because of parenteral nutrition, there will be cholestasis, steatosis, steatohepatitis, ductopenia, and fibrosis. Some infants can develop rapid fibrosis progression. And it is a very fatal condition because the mortality will be 60%, especially in pediatric population. So these are the various complications along with our nutritional deficiencies and malnourishment. How can you manage? Main nutritional aspect, how we can manage, and specific therapies. Nutritional aspect, we just need to supplement early parenteral nutrition and try to supplement with enteral nutrition. So if the patient develops liver disease, intestinal failure associated liver disease, consider adding fish oils and try more oral, decreasing the TPN. Hydration, electrolyte corrections. If D-lactic acidosis occurs, stop the carbohydrates and then supplement with other forms, more of proteins and fatty acids and amino acids. Just decrease on the carbs. Antibiotics, hydration, and thiamine can improve D-lactic acidosis. Bone disease, supplement vitamin D and bisphosphonates. These are specific for complications. Okay, advanced therapies. What can be done is reversal or interposition. Surgically, there can be some interposition of segments that can be done. Some suturoplasty, lengthening, transplantation. Intestinal transplantation is something that can be considered in these patients. Okay, intestine indicated if the bowel length is very, very small, less than 60 centimeters of bowel, with parenteral nutrition related complications like intestinal failure associated liver disease. And some hormonal analogs like to decrease the secretions, teglutide. So this can be used. So prognosis on the long term, it all depends on the age of the patient and the underlying disease and the length of the intestine. Less than 60 centimeters, the patient will be on prolonged lifelong parenteral nutritional support. It is one of the indication for transplant. So and also presence of ileocecal valve improves the independence. So this is about short bowel syndrome. Any doubts or anything? Anybody who wants to? So if there are no doubts, we'll move on to the next topic. So we'll begin with endocrine now. So most important and most commonly asked in ICU, that is the practical aspects. Okay, glucose control in ICU. So it is very, very important. So is glucose control important at all? What are the risks and complications and what are we worried about? So it is just not hyperglycemia that we are worried about. It is also about the glycemic variability. Okay. The variation or fluctuations in glucose level, that is also very important. And hypoglycemia is another important concern. So why is hyperglycemia important or the adverse effects of hyperglycemia? Hyperglycemia increases mortality and morbidity, increases the risks of infections, acute renal failure. It increases the mechanical ventilation in hospital day and cardiovascular complications. Glycemic variability increases mortality and adverse outcome because of high oxidative stress and endothelial damage. Hypoglycemia, it is a very important concern. Very low glucose or sugar levels increases mortality. It not only increases the mortality, if not treated in appropriately or immediately can result in permanent neurological damage, can result in seizures, arrhythmias, SIRS response, and it will inhibit the corticosteroid response to stress as well. And no, and it impairs the sympathetic nervous system responsiveness, causes cerebral vasodilatation. So patients who are hypoglycemics, who do not receive appropriate timely treatment, will have neuroglycopenic symptoms that can last for a long time. Okay. So causes of hyperglycemia in the ICU, it could be due to three factors. One, stress per se. It increases the cortisol catecholamines. So there is high counter-regulatory hormones that are increased, and there will be insulin resistance. So this is one mechanism. Second, increase in the cytokine levels. This is also one of the counter-regulatory hormones, cytokines, tumor necrosis factor alpha, contributing to insulin resistance. Third, the nutritional aspect might be compromised. The nutritional aspect also plays an important role, especially the parental nutrition. So these are the three important factors. So the patients with hyperglycemia, you can classify into three categories: patients with known diabetes, unknown diabetes mellitus, and new onset hyperglycemia. So how do you differentiate between these three? So known with a history, and you have already a criteria. You're fasting more than 126, postprandial more than 200, HbA1c more than 6.5, classical symptoms of hyperglycemic crisis. Undiagnosed, you go with a HbA1c more than 6.5 and a blood glucose more than 140. Okay. And new onset, here the HbA1c is going to be low, and it is predominantly due to stress induced as well as extrinsically admitted because of your catecholamines. You'll be giving a lot of vasopressors, adrenaline infusion, steroids, and parenteral nutrition coupled with insulin resistance. So these are the main reasons. There will be enhanced lipolysis, glycogenolysis, and gluconeogenesis. So remember, compared to the diabetes and the undiagnosed diabetes, these patients who have a new onset hyperglycemia have threefold higher mortality. So what is the range that you need to maintain the glucose control, glycemic control in the ICU? So we have a target of 140 to 180. How did we arrive at what is the trials and how did we come to a conclusion of this? So this is something you'll be asked in many of your practical exams or your bedside discussions. So everybody will be doing this. It will be a rapid revision that I'll be going through. So first will be a Vandenberg et al. Trial that is in 2001, also known as the Leuven-1 trial. This was done in mainly cardiac surgical patients, wherein they compared intense insulin therapy to conventional glucose management. Here, the targets of intense insulin therapy was 80 to 100, whereas conventional was 180 to 200. They found that the intense insulin therapy showed a significant decrease in mortality. It was beneficial, okay? Decrease in ICU as well as hospital mortality. So it was 4.6% versus 8%. It also decreases the critical care illness related polyneuropathy, bloodstream infections, renal replacement needs. So all these things were decreased. Next came the Leuven-1 trial. So these were predominantly in cardiac surgery patients. When they tried to replicate this in the medical ICU, that was in 2006, they did not find any benefit in mortality. But okay, the difference was 37.3 versus 40. Okay, this was the difference, and there was no significant difference. But the patients in intense insulin therapy had more incidence of hypoglycemia. So the incidence of hypoglycemia was almost 18.7%. So this was something that was alarming. So next two trials were done, the glue control in 2009, this also found the increased incidence of hypoglycemia in patients who received intense, intense insulin therapy. Next was the WISE-UP study. This also showed the risk of adverse events related to hypoglycemia. So then came the nice sugar study that was in 2009. This was a multi-center trial in medical and surgical ICUs where they compared intense insulin therapy 80 to 108 and conventional was less than 180. So they found there was increase in the mortality in and severe hypoglycemia. So they found it was not only ineffective but it was harmful. So they did not they did not recommend a tight glucose control for hyperglycemia. Okay, so this is how we arrived at. And the next studies were COIDs, that is corticosteroid corticosteroid treatment and intense insulin therapy for septic shock in adults. So this also did not find any mortality. So as per the American Diabetes Association, so we follow the 140 to 180 glycemic targets. So that's about it. Diabetes Association and the Joint British Diabetes Society, both the guidelines together. Okay, the definition of DK as per the ADA, that is American Diabetes Association criteria will be this. The triad DKA triad involves metabolic acidosis, ketosis, and uncontrolled blood sugar. So as per ADA, blood glucose more than 250 grams per deciliter, milligrams per deciliter, arterial pH less than 7.5, bicarbonate less than 18, anion gap more than 12, a positive serum or urine ketone, that is a serum ketone more than 3 millimoles per liter. So this is the criteria as per the ADA. As per Joint British Diabetes Society, so you remember D, K and A. So here the glucose levels more than 198. K for ketonemia, that is more than 3 millimoles per liter of ketones, or a urine ketone dipstick, that is 2 plus positive, and a bicarb level less than 15 or a pH less than 7.5. Here the anion gap is not included. That is the difference between these two, and the blood sugar levels are slightly different. So in incidence, children mostly type 1, adults mostly type 2. The case fatality rate is less than 1%. So mortality increases with the age as well as comorbids. Coming to the pathophysiology. So there can be an absolute insulin deficiency. Mostly in the ICUs, it is going to be a relative deficiency. So relative insulin deficiency with increase in the because of stress, also extrinsically administered vasopressors, catecholamines, so counter-regulatory hormones will go up. So there is an imbalance between insulin and counter-regulatory hormones. Decrease in insulin causes increased lipolysis, increased free plasma fatty acids, increased hepatic free fatty acids. Okay, because of these fatty acids, there is more ketone production, and these ketones are neutralized by buffers, nothing but bicarbonate. So as the bicarbonate buffers the ketones, the bicarbonate levels goes down. This results in high anion gap metabolic acidosis. Also, because of increase in glucagon level, there is increase in carnitine palmitoyl transferase. So this also causes ketosis. So the other thing is because of increase in the counter-regulatory hormones, there is increased gluconeogenesis, there is decreased glucose utilization and increased glycogenolysis. Okay, glycogen is broken down. There is new production of glucose and utilization is also impaired. Because of all these three mechanisms, there is hyperglycemia. So due to hyperglycemia, there is increase hyperosmolality. So due to hyperosmolality, there is diuresis that goes on. There is osmotic diuresis because the renal threshold for the sugar levels will be the it will exceed the renal threshold, so there will be glycosuria, because along with sugars there will be water that is carried away, so there is osmotic diuresis. Because of osmotic diuresis, patient will be volume depleted, hypovolemic, and there will be loss of electrolytes along with this, along with the water. So, and because of hyperosmolality, it affects the brain. So, there will be depressed mental status. So, this is the main pathophysiology of DKA. So, we have looked into the pathophysiology, and also because of hypovolemia, there will be impaired tissue perfusion, increased lactate. So what are the ketones, predominant ketones? Beta hydroxybutyrate, acetone, and acetate. Okay, these are the three ketones that are produced in DKA. So triggers of DKA, just remember any inciting event. Mostly it can be non-compliance to the already, the patient might be non-compliant to the drugs, or it could be a new onset diabetes, or infection, stroke, trauma, any surgery, alcohol, alcohol intake, myocardial infarction, or any other stress factor. Okay, or any sympathomimetics drugs, thiazides, so all these things can cause steroids. So other two important factors that you need to remember is SGL2 inhibitors. So these are gaining more importance these days. That is dapagliflozin, empagliflozin, and canagliflozin. So these drugs cause euglycemic decay. Also, the immune checkpoint inhibitors, anti-cancer drugs like pembrolizumab, nivolumab, and ipilimumab. So these drugs also cause decay. Symptoms usually polyuria, polydipsia, mental obtentation, abdominal pain, dehydration, acetone breath, and cosmol breathing. So these are the symptoms. Differentiate between euglycemic DKA and HSS. Euglycemic sugar levels are almost in the normal range with acidosis, pH less than 7.3, bicarb less than 18, ketonemia will be there. So this is mainly imbalance between insulin and counter-regulatory hormone with a raised glucagon and insulin ratio. The ratio between glucagon and insulin will change. Okay, this happens mainly due to recent use of SGLT2 inhibitors. It can also happen in pregnancy, surgery, or any kind of gastroparesis, ketogenic diet, alcohol intake, any fasting state. So this can happen. Criteria for HHS is a plasma glucose level more than 600. Okay, and the serum osmolality should be more than 320 milliosmoles per kg. Because of significant raise in the glucose level and high osmolality, so there is osmotic diuresis which has happened, and there will be profound dehydration with an average deficit of about 9 liters. And the pH is usually, there's no acidosis. Mainly it is due to the symptoms are mainly due to hyperosmolality. So usually acidosis may not be there, or even if it's there, it will be mild. So pH is usually more than 7.3, bicarb more than 15. Small ketonuria can be present. So there will be alterations in the mental status of the patient as well. So these are the various definitions. So comparing between DKA and HHS, we already looked into. So in terms of the type, DKA usually type 1 occurs, it mainly occurs in type 1. HHS usually in type 2. The onset is usually rapid and usually within 24 hours, whereas in HHS it is usually insidious over several days. The fluid deficit is almost 6 liters. Here, it's a very huge deficit, 8 to 10 liters. The blood glucose levels, modest hyperglycemia will be there. Here, severe hyperglycemia more than 600. The key metabolic disturbance is metabolic acidosis, serum, ketones. Here, it is hyperosmolality more than 320 milliosmoles per kg. Clinical features, abdominal pain, cosmal respiration, fruity odor, hypotension, tachycardia, and drowsiness. Here, because of the volume deficit, hypotension, poor skin turgor, tissue perfusion deficit, there can be tachycardia and altered mental status. Okay. The mortality is very high in HHS compared to DKA. So how will you treat? First, categorization of mild decay, of decay, mild, moderate, and severe. This is based on the pH bicarbonate anion gap. Okay, usually if the pH is between 7.25 to 7.3, bicarbonate between 15 to 18, and the anion gap is more than 10, it is classified as mild decay, wherein the patient is alert. Moderate, the pH goes down even more, 7 to 7.25. The bicarbonate is 10 to 15, and the anion gap is more than 12. Patient is alert, but can be drowsy as well. Severe pH less than 7, bicarbonate less than 10, anion gap more than 12, patient is in stupor or coma. So this is the class A. When you're managing investigations that you need to look at factors, what all you will glucose, ketone, and you will for lipstick. This related to members and creatinine and the serum electrolytes, because you're more worried about potassium before starting your insulin. So electrolytes. And along with that, other investigations which will help investigating your cause depending on the patient history, ECG, echo, or ruling out infections. So any other X-rays or any cultures. So depending on to rule out your inciting event. So that you need to do. First, how will you manage? First and foremost will be factor that you need to do. So after you adequate fluids, what fluid to give, how much to give. So that is our concern now. So intravenous fluids remain the first modality of treatment. So you start with what fluid. Most of the guidelines have recommended 0.9% sodium chloride. But what is the problem with large volume resuscitation of normal saline is that we are more worried about the hyperchloremic acidosis, and then the high make that is you're worried about the AKI. So as per the scope DKA study, balance salt solutions have shown faster resolution of acidosis and lesser length of hospital stay with acetone-based balanced salt solutions. So the balanced salt solutions are preferred, as well as smart and salt ED trials have shown that balanced salt solutions compared to normal saline have benefit, okay, because this can lead to hyperchloremic metabolic acidosis. So how much to give? 15 to 20 ml per kg in the first hour to start with. So first, after correcting the fluid deficit, then look at the potassium levels before starting your insulin. So the potassium levels should be at least 3.3 millimoles before starting insulin, because if you start insulin, there can be a intracellular, transcellular shift of the potassium resulting in hypokalemia and adverse events, arrhythmias related to significant hypokalemia. So you need to be worried about, and always replace potassium. 30 to 40 millimoles intravenously in every volume of fluid, like every unit of uh, um, fluid that you're going to be giving. So depending on the levels, like if it is 3.3, you supplement 30 to 40 until your serum potassium is more than 3.3. If it is 3.3, between 5, you have to give 20 milliequivalents in every liter. If it's more than 4, do not supplement. So this is the guideline. Next is starting your insulin. So how much to give? So always avoid a priming. Initial conventional recommendation was to give in a bolus, but these days the recommendation is to start on an infusion directly, zero point 0.1 unit per kg per hour, followed by and you have to continue based on your blood sugar levels. So if the sugar levels drop to less than 250 milligrams per deciliter, then you have to add either a dextrose-based solution to avoid hypoglycemia. So, and you have to maintain a target between 140 to 200 until the anion gap is closed, that is less than 12 milliequivalents. So once you start insulin, you monitor your insulin infusion, monitor your sugars hourly, and if it's less than 200, add on a dextrose-based solution, continue insulin infusion until the acidosis resolves, your anion gap is closed. Okay, you can start on a long-acting insulin simultaneously as well. The recommendation is 0.25 unit per kg of long-acting insulin. So how frequently you need to monitor. So glucose measured hourly, serum electrolytes, ABG, anion gap. So all these things second to fourth hourly, depending on the patient status. And then you can monitor the beta hydroxybutyrate, the point of care testing wherein we use the method to measure at the bedside, that uses the beta hydroxybutyrate, wherein the urine levels measures the other acetone, acetoacetates, and beta hydroxybutyrate as well. So remember that as well. So bicarbonate, is there any use of bicarbonate? Bicarbonate is controversial. Only if the pH is less than 6.9, you can start on, you can give a bicarbonate. That too, how much needs to be given? So this is an isobicarb infusion. A 5% dextrose 400 ml with 100 ml of soda bicarb can be added, and it can be given at a rate of 200 ml for first 2 hours until the pH. So you continue this infusion until the pH is more than 7. So that is the AD. So this is usually as per consensus statement. This is not as per any guidelines. ADA guidelines do not recommend the use of soda bicarb until the pH is less than 7.5. So what is the adverse effect of bicarbonate? It can result in paradoxical cerebrospinal CSF acidosis, cerebral edema, sodium overload, and hypokalemia. So that is why you have to avoid it. So complications of decay related, treatment related, mostly fluid resuscitation. When you are resuscitating the fluid, especially in pediatric population, the most important thing that you need to be worried about is cerebral edema, pulmonary edema, cardiac dysarrhythmias related to hypokalemia, and hypoglycemia. So how much reduction in the blood glucose levels that you have to target? 50 to 75 milligram per deciliter per hour, and a ketone reduction of 0.5 millimoles per liter per hour. So, and a increase in venous bicarbonate by 3 millimoles. So this is your targets or your response to therapy. So decrease in blood glucose levels, reduction in the blood ketone, and increase in your venous bicarb. So other targets is maintaining your good urine output, potassium concentration between normal level 4 to 5, and then reduction in your plasma anion gap. So the other differentials for DKA would be other causes for acidosis, uremia, lactic acidosis, glycosis, starvation ketosis, alcohol, and salicylate. So how do you identify resolution? As per the uh, Joint British Diabetes Society, so if the pH is more than 7.5, 7.3, bicarbonate more than 15, ketone levels less than zero point 0.6. So this is the criteria as per the Joint British Diabetes Society. Americans 7.3 pH, more than 15 bicarbonate, anion gap less than. So here they mention the ketones, whereas the Americans mention the anion gap. So resolution of HHS is mainly the sensorium improvement. Okay, improvement in the GCS, blood glucose levels less than 250, and serum osmolality less than 310. So this is the timeline of management. So within 0 to 60 minutes, diagnose, resuscitate, immediate management. So look, pH, looking for pH, first fluids, electrolytes, start insulin, and check in for your blood gases, serum ketones, pH, and all that. 1 to 6 hours suppression of hyperglycemia, ketogenesis, and organ support if needed. And again, reassess all the values. 6 to 12 hours, monitor response to treatment, watch for complications. Okay, look at the mental status. That is, patient might be going into cerebral edema. So here, suppression of ketosis happens. So 12 to 24 hours, that is a period wherein your DKA resolves, resolution of DKA, and you start transition of intravenous insulin to a subcutaneous form. Convert to a subcutaneous form and then again watch for rebound hyperglycemia and ketosis. So this is the complete algorithm of how you need to manage. We have talked about this in detail. Okay. So bicarbonate, if pH is less than 6.5, 6.9, and you'll have to monitor every second hourly. Insulin, the difference in DK and HSS management is that the insulin infusion started at 0.14 unit per kg. And then if the levels drop to in DKA, if it is less than 200, you start a dextrose-based solution. So here, if it is reaching less than 300, what you do is you reduce the insulin levels and then you consider glucose-based solution, maintaining between 200 to 300. Here, below 200, you add on dextrose base. Here, between 200 to 300, you add on dextrose base solution. So after resolution, you always bridge over. You start the subcutaneous insulin, and after 1 or 2 hours, then you discontinue the intravenous form. Okay, potassium supplementation that we already looked into. So that is about management of DKA and HHS. So next, Dr. Jasmine, if Dr. Jasmine is there, can I ask her to join, take over from here?
Yes, Dr. Priya, I'm here. I'll just share my slides. Just give me a minute.
Sure. Hope everyone is okay with the previous aspects, whatever we covered, the previous questions. Is there any doubts or anything that you want to ask? Anything that is not clear? Please, you can write it in the chat box.
The recording has stopped.
Ma'am?
One minute, buddy. So right now we'll continue with where we stopped yesterday.
This meeting is being recorded.
We had completed community-acquired pneumonia. Now we'll go ahead and see ventilator-associated pneumonia. So, how do we define ventilator-associated pneumonia? So there is a clinical definition and there is a CDC definition. For the clinical definition, there are a few specific criteria which you should mention. The first one being that it should occur 48 after in a patient who has been on mechanical ventilation for more than equal to 48 hours. The next thing, there should be a new or a progressive infiltrate. The third thing is that there should be some signs of an infection like fever, purulent sputum, leukocytosis, worsening oxygenation, or altered respiratory mechanics. The fourth thing is that there should be a positive respiratory specimen, either increase in the neutrophils or growth of a pathogen above a predefined threshold. Okay, So these 4 points. First is the duration of mechanical ventilation. Second is the X-ray. Third is the clinical signs, and fourth is the culture. So these 4 points define a VAP. So the CDC definition that is given is not a clinical definition. It is purely for surveillance purposes. So what are these CDC definitions? So they are called ventilator associated events. The first ventilator associated event is a uh, ventilator, sorry, ventilator associated condition, also known as a VAC. So for that, a patient already be on stable or minimum PEEP or FiO2 for at least 48 hours. And after this, suddenly there should be either an increase in the PEEP or an increase in the FiO2. Increase in the PEEP by 3 or increase in the FiO2 by 20% or 0.2. And this increase should be sustained for 48 hours. So this is the definition of a ventilator associated condition. That means 48 hours of stable PEEP and FiO2 followed by increase in the PEEP of 3 or an increase in the FiO2 for 0.2. This is sustained for 48 hours. When is this called an IVAC or an infection related ventilator associated complication? For that, you need one thing. First thing that you need is clinical. What is that? Temperature, either a low temperature or a high temperature, or WBC, either a decrease in the WBC or increase in the WBC. The second thing that you need is addition of a new antibiotic, which is continued for 96 hours. That also within 48 hours of the VAC, within 48 hours of this occurring, the antibiotic was added, and it should exclude the first 48 hours of mechanical ventilation. Okay. So this is purely a surveillance definition, just to retrospectively count the number of your VACs, IVACs, sorry. So I'm again going through your infection-related ventilator-associated complication. First is clinical, low temperature, high temperature, or drop in WBC count or increase in WBC count. Addition of a new antibiotic for 96 hours at least. And this is within 48 hours of a VAC after first 48 hours of mechanical ventilation. Now, an IVAC can be a possible pneumonia or a probable pneumonia. For a possible pneumonia, you need the sputum or a bowel sample showing 25 neutrophils per field or a positive culture. Uh, when when you have 25 neutrophils per field along with a positive culture, which is quantitative or semi-quantitative, meets the quantitative or semi-quantitative criteria, then it's called a probable pneumonia. Okay, so these are purely surveillance-based definitions, which are unfortunately asked in exams. So next is the etiology of VAP. So you have to, the most common organisms for ventilator-associated pneumonias are staph, including MRSA, Pseudomonas, E. coli, Klebsiella, Enterobacter, Acinetobacter baumannii, Stenotrophomonas, and Burkholderia. So these are more common, all your hospital-acquired bugs, these will come in as the etiology of a VAP. What are the risk factors? The risk factors for getting an MRSA and or a resistant gram-negative VAP have been labeled here because these are also again specifically asked. These risk factors are purely related to VAP. So what are the risk factors common to both MRSA and resistant gram-negative bugs? One, use of IV antibiotics within 9. Factors which are individual to both MRS and MDR. First is prior colonization. Next is local resistance more than 10%. So if your local ICU resistant pattern is of more than 10%, then your empirical therapy itself will be one that will cover a resistant gram-negative bug. Or if you don't have any, you don't know your local susceptibility patterns, in that case, you will cover for a resistant gram-negative bug. Similarly, for MRSA, prior colonization or prior isolation, uh, local prevalence of more than 10% and or unknown susceptibility patterns. So all of these will help, these risk factors will help us understand whether we should give empirical broad spectrum coverage or empirical coverage for such resistant bugs. So coming to the pathogenesis. So for the pathogenesis is basically a balance between both the virulence of the microbes and host factors. So how do the organisms enter? One is the microaspiration of organisms which have already colonized your oropharyngeal tract and maybe even to a lesser extent on the GI tract. So this is the primary route of entry of the organism into the lung. Other possible routes include first is contaminated respiratory devices, contaminated water reservoirs, hands of healthcare workers, and tubings which are contaminated. So these are all the possible routes from which these bugs will reach the lung. This combined with host factors such as uh, more immunocompromised condition due to compromised stomach pH. Okay, so when your stomach pH is actually protective against a lot of organisms, and when your stomach, we give PPIs or acid suppressing drugs, what we do is we promote bacterial overgrowth in the GI tract, and this is one of the additional factor that contributes to the occurrence of a VAP. The clinical presentation. So the clinical presentation I've divided in this table of symptoms, science, what will you see on the ventilator mechanics, lab findings, and imaging. Okay. Symptoms, what patient is already on the ventilator. So the only possible symptom you will see is dyspnea. Science, fever, tachypnea, desaturation, increase of purulent secretions, hemoptysis, bronchi crackles, decreased breath sounds, and bronchospasms. Ventilator mechanics, how will the ventilator mechanics change? The tidal volume goes down, or the inspiratory pressures go up, or there is a change in the FiO2 or PEEP requirements. This coupled with lab findings, lab you'll see leukocytosis, and in imaging, you can have X-ray, CT, and USG showing you any more infiltrates in the lung. Now coming to the microbiological diagnosis. For the microbiological diagnosis, what it is advisable to have a respiratory sample before the first antibiotic if possible. The ESICM guidelines prefer an invasive sampling, that is either a mini ball, a bronchoscopic ball, or a protected specimen brush sample, and always quantitative cultures are preferred. So first is your bronchoscopic ball. Now, your bronchoscopic ball, you are collecting the sample right from the fourth order bronchus. You're infusing and aspirating some sterile saline at this level. And this is specifically useful in immunocompromised patients in whom you tend to have more and more atypical infections. So tend to respond lesser to antibiotics by virtue of a diminished immunity. So doing a bronchoscopic bowel for sample collection has shown to reduce the antibiotic overuse, enable more rapid de-escalation without impacting mortality or length of stay. So how do you interpret a bronchoscopic bowel sample? If it has less than 50% neutrophils, and acute bacterial pneumonia is unlikely. And the cutoff for the culture growth of any bug is around 10,000 colony forming units per ml. Then next is your protected specimen brush. So here there is a brush with a protective sheath, which is collected from the airway wall. The sample is collected by this brush from the airway wall. The distal end of this brush will be cut and it will be cultured. So this is a more invasive method of collecting the sample, and it's associated with a risk of hypoxemia and barotrauma. But the cutoff over here is lesser. The growth of any organism of at even 1000 CFU per ml is significant. So try and understand why are we doing this, because our respiratory air system now is already going to have a lot of colonizers. So just growing a bug might not really implicate that it is causing a VAP. So that is why there are specific more invasive methods advised for sample collection. The third is a mini ball. So in a mini ball, what do? We insert a catheter in the AT tube till a resistance is found, and we insert at least 50 ml sterile saline almost 3 times and aspirate that saline with a syringe. Over here, you are reaching up to the second, third generation bronchus. So it is an advantages as compared to your bronchoscopic ball and PSP. It is easier, it has less risk of complications, and it is less likely to be contaminated, and still you might get a deep alveolar sample. The cutoff over here is 10,000 colony forming units per ml. So for bronchoscopic ball, it is 10,000, mini ball it's 10,000, PSB it is 1,000. And the final is the easiest thing, is to take an endotracheal aspirate. Here the cutoff, uh, here you have 6 zeros in the cutoff to properly say that this growth of an organism is causing you the VAP. Or if you have neutrophils less than 50%, you can exclude VAP. Gram stain might sometimes give you a pathogen, a rough idea of the pathogen you're dealing with. And the culture, like I told you, the cutoff over here is higher. Next comes your severity scoring systems. So there are two severity scoring systems. Earlier, what was used was a CPIS, or the Clinical Pulmonary Infection Score, which has now become your modified CPIS, or the modified Clinical Pulmonary Infection Score. We can focus on the right side of our slide right now. So the first thing over here is temperature. Second is WBC. Third is pulmonary secretions. Fourth is oxygenation, and fifth is X-ray. So these 5 findings amongst the temperature, each of these are given a point from 0 to 2. If you see in the earlier CPIS score, they had elaborated X-ray in 2 points. One was pulmonary radiography, and second was how is it progression. This whole thing is combined into 1 point as chest X-ray over here, whether there is an infiltration, whether it is disseminated, whether it is local. And depending on the type of the infiltration, the score is given. So the progression is removed from the modified score. And the culture of tracheal aspirate, which was initially used, is also removed, because obviously if you wait for the culture, you cannot, by the time it's too late to now judge the severity of the score, severity of the VAP. So that has also been removed. It is only based on clinical, that is your temperature, WBC, the type of the pulmonary secretions, PF ratios, and X-ray. These 5 things are included in the modified CPIS. Now coming to the treatment. So treatment, initially you will start the patient on empirical antibiotics. And once you have a culture, you will go ahead with a more organ specific antibiotic. How do you decide your empirical antibiotics? We have seen the risk factors for MRSA, right? So if you're suspecting an MRSA based on these risk factors, you will give vancomycin or linezolid. If you're suspecting an MDR gram-negative organism, then you need to do a pseudomonal cover, which is either piptazo, cefepime, ceftazidime, meropenem, or astronam. And if neither of these are there, you can stick to piperacillin, tazobactam, or cefepime. Now, once you have a culture, then depending upon what organism you're growing, you narrow down your antibiotic to the specific antibiotic. MRSA will be covered by linezolid or vancomycin. If you have an MSSA, you prefer cefazolin 2 gram 8 hourly. If you have a gram-negative bug which is not MDR, you go for piperacillin, tazobactam, cefepime, or ceftazidime, or any other cephalosporin equivalent to this. And if you have an MDR, then you treat it according to the organism. All the MDR bugs will be covered in your infection classes, so you know which antibiotic regimen to use for which bug when it comes to resistant Pseudomonas, resistant Klebsiella, and resistant Acinetobacter baumannii. Now coming to the de-escalation. So if you don't have a growth, you can decide to de-escalate from a broader spectrum to a narrower spectrum, or for if sorry For an MRSA, if you don't have a growth, or if your even your nasal swab is negative, then you can de-escalate. For a gram negative, also if there is no growth for the 48 to 72 hours, you can de-escalate. Duration of antibiotics is 7 days if the patient is getting better, or you can even consider procalcitonin guided therapy. Extended duration, when do you extend? If there is a metastatic infection for gram negative bacteremia, if your blood culture is positive, if there is a slow clinic response, compromised patient, if you find evidence of, only in these specific cases you 7 days. Role of nebulizer, this is going to an entire lecture in itself in one of your sessions. So, and nebulizer makes glycosides. It's there is proven benefit is used to improve the local antibiotic concentration at the site of infection. Frequent VAP if you see you uh, this bundle, the recommended head and elevation, uh, daily sedation, vacation, daily oral care with chlorhexidine, disease probability. See the latest CDC recommendations, a lot of these will not be recommended. So this is more of an older bundle, but right now what is more commonly used is a checklist for VAP prevention, and this is given to us by CDC. Okay, so what they categorized all additional practices not recommended. That means these things should definitely not be done. And the one which have no recommendations. That means they have not they made any specific guideline on what to do. Of these essential practices and additional practices, you must know. Okay, this was a question for us in our exam. They specifically ask either only essential practices or only additional practices. Amongst this is what I have mentioned in this slide is for only VAP. You have similar checklist for even your CRBSIs, and even so I think even for COTI there is one, but you have to make sure that you go through these checklists and as much as possible be a little confident about writing an answer on any of these. So amongst essential practices, the first is avoid intubation itself. So you prefer either an NIV or an HFNC. The second is minimize the sedation. In that, they tell you to try and avoid benzodiazepines and prefer other agents over benzodiazepine, and use a protocol to minimize sedation, and implement a ventilator liberation protocol. The third essential practice is maintain and improve physical conditioning of the patient. Fourth is to head and elevation to 30 to 45 degrees. Fifth is provide oral care with tooth brushing being the key word over here, without chlorhexidine. So like you saw in the previous bundle, there was, sorry, what was recommended is chlorhexidine. Chlorhexidine is not anymore recommended. In fact, they tell you to do it with just toothbrushing without chlorhexidine because of the risk of chemical pneumonitis with chlorhexidine. And provide early enteral over parenteral nutrition, and change the ventilator circuit only if it is visibly soiled or malfunctioning. So these points have to be at the tip of your fingers because it was a question just recently. So similarly for other hospital-acquired infections, there are such checklists. Please go through them. Amongst the additional practices means these interventions did improve outcomes in some populations but caused a risk in others. So it is not said essential. It is like an additional thing. You may or may not do this. Now, over here, they say use selective oral or digestive decontamination, but it is only in countries where there is low prevalence of antibiotic organisms. So, for us, this part is not applicable because SOD and STT both are associated with an increased risk of propagating resistant bugs. The second additional approach is using an endotracheal tube with a subglottic secretion drainage port if you're anticipating that this patient is going to need ventilation for more than 48 to 72 hours. Third point is to consider early tracheostomy. And fourth is consider prospiralic feeding over gastric feeding when patients have gastric intolerance or a high risk of aspiration. So, mind you, these are only additional approaches, only if it's applicable in your patient. Not recommended में आता है chlorhexidine. So don't write chlorhexidine in VAP prevention bundle. Not recommended are probiotics, ultra thin polyurethane ET tubes, tapered ET tubes, automated control of the cuff pressure, frequent cuff pressure monitoring, silver coated ET tubes, kinetic beds, prone positioning, chlorhexidine bathing. Now, chlorhexidine bathing does not as come becomes as a not recommended for VAP, but when you read CRBSI, they do tell you to do chlorhexidine sponging daily for patients having a central line. Okay, so the things that have not found to have any impact on VAP rates or duration of ventilation or mortality are using stress ulcer prophylaxis, monitoring GRV, that is residual gastric volumes, or initiating parenteral nutrition earlier. And there is no specific recommendation on using a closed endotracheal sectioning system. Okay. So now moving on to the next topic is ARDS. So ARDS, there is a question on the evolution or criticizing each of the definitions. So need to know how it started. The first definition came by Ashbrook, followed by Murray. Now this is your Murray score, which you use very commonly, especially when putting your patients on ECMO. So this is the definition of that this Murray score, which was initially actually the defining feature of ARDS in 1988. The first thing is chest radiography. Second is your PF ratios. Third is your PEEP. Fourth is your respiratory system compliance. So these you should know that at least know the components of the Murray score. So if the total score is more than 2.5, it indicates there is severe lung injury or ARDS. So it depends on chest X-ray, PF ratios, PEEP, and compliance. Then came your AECC. AECC is your American European Consensus Conference. This gave you 4 criteria to define ARDS. First, it should be an acute onset. Second, there should be bilateral infiltrates on the X-ray. Third, they said you have to measure the pulmonary wedge pressure and should be less than 18, or no clinical evidence of a high atrial pressure to rule out cardiogenic causes of lung edema. And fourth, they defined hypoxemia. Over here, if you see, they defined hypoxemia as ALI and ARDS. So if it was less than 300, your PF ratio, then it was called ALI. And if it was less than 200, your PF ratio, it was called ARDS. Okay. So what are the problems with this definition? If you can see, it said only acute onset. How acute? 1 day, 2 day, 3 day, 8 days, 14 days was not mentioned. Second thing is bilateral infiltrates can mean anything. It can mean a collapse, it can mean a consolidation, it can mean an effusion, not necessarily just be a lung infiltrate. So this was not a clear-cut definition. Third thing problem was they said you use a pulmonary wedge pressure, means you have to use a PA cath to just define ARDS over here. And the fourth problem is they they introduced the term ALI. So it was somehow thought that ALI was a concept different from ARDS, but it was not so. ARDS and ALI are the same concept. Okay, so these are the pitfalls of the AECC definition. So now to overcome these pitfalls came the Berlin definition in 2012. The Berlin definition, they defined that acute as 1 week, 1 week of a known clinical insult or a new worsening respiratory symptoms. They defined the infiltrates. That means there should be opacities which are not explained by effusion, lung collapse, or nodules. They defined the origin of the edema just by clinical assessment or cardiographic assessment. You don't need to do you don't need a PCWP over here. And they categorize the oxygenation as mild, moderate, severe. So they removed the term ALI from their definition. Mild was when the PF ratio was between 200 and 300, along with the CPAP of more than equal to 5. Moderate was between 100 to 200, along with a PEEP of more than equal to 5. And severe was a PF of less than 100, along with the PEEP of more than equal to 5. So there a lot of the problems with the AECC definitions got covered. First is we got a proper defined duration. Second is we got a definition of the chest infiltrates. Third is we don't have need a PCWP invasive measure to just define it as non-cardiac. And the categorization of the hypoxia included something called PEEP. So your PF ratios are not the only defining feature over here, right? If you can have a lesser FiO2 if with a higher PEEP, and that patient might still be in a severe category. So they did give some recognition to PEEP, but the problem is they only said 5. Now, anything more than 5 is most of your patients in the ICU are going to be on a minimum PEEP of 5. So anything more than 5 was not a very good categorization, but at least they recognized PEEP in their definition. So, what are the drawbacks of the Berlin definition? Like I said, the first thing was PF ratio. I told you they did not standardize PEEP more than 5. Now chest X-ray, they said only chest imaging. They said only X-ray. Na? There was a little inter-observer variation in this, and it did not account for newer modalities like CT and ultrasound. They, uh, they did not mandate an echocardiography to rule out cardiac failure. So is they say this is a drawback because there's a risk of misclassification. And the timing. So though we had a problem with the AECC definition not defining the acute onset in a proper duration, the Berlin definition just came up with an arbitrary duration of 1 week. Okay. Now, for some causes of ARDS, like if you see pancreatitis patients, they are for weeks sometimes. The disease progresses for a week, for multiple weeks. In that case, if an ARDS develops later as a complication, then it does not really fit into this criteria. Trali might come immediately after blood transfusion. So then a lot of times these causes don't really fit into the 1 week duration. So it is very arbitrarily mentioned 1 week. Fifth problem with this Berlin definition, it is said that there should be a proper biomarker, to say yes, this is ARDS or this is not ARDS. So there's no proper biomarker. Uh, it makes the definition a little more objective. Applicability, this is only for adults, it's less validated in children, and it does not include patients on HFNC. And the last problem is that it has a questionable generalizability in areas where there is resource limited settings, where you don't have a proper blood gas available to check your PaO2 always. So these were the drawbacks of the Berlin definition. So this is also a question in itself, criticize the Berlin definition. So I have included all of these points. Now, next comes the Kigali modification. So Kigali modification, what they try to help the define ARDS in resource limited settings. The differentiating points over here is, first is they added SF ratio. Okay, they said not, so if you are in a resource limited setting where you don't have an ABG, you can directly see the saturation and FiO2 ratio. And if it is less than equal to 315, you can call this hypoxia. They said they did not put the PEEP requirement. So if you're in a resource limited setting where there is no proper NIV or BiPAP available, so then they removed the criteria of adding a PEEP, and also they added ultrasound. So if there is no if the immediate you can't do an immediate CT, then at least a bedside ultrasound to define pulmonary opacities. So these were the three things they modified in the Berlin definition just to fit the definition in areas with resource limitations. And the most recently that we have is the new global definition of ARDS. Okay. So over here, whatever is different is mentioned in this diagram in purple. Okay. So they added one lung ultrasound in the radiological features with by a trained professional. Second, they added the role of HFNC. So, to categorize mild hypoxemia, they did define them either with NIV, CPAP, or HFNC with a flow of 30 liter per more than 30 liter per minute. The next difference in the new global definition is they also mentioned the SF ratio as a criteria to define hypoxemia, and they also gave they also eliminated the role of PEEP or flow rate in resource limited settings. And this was further divided into mild, moderate, severe as an SF ratio of less than 148 being severe, 148 to 235 being moderate, and 235 to 315 being mild. So this is the latest update that we have in the indirect insult. Direct, whatever happens to the lung, you can write aspiration pneumonias or any pneumonias, inhalational injury, contusions, fat embolism, drowning. Indirect insults include sepsis, severe trauma, pancreatitis, CP bypass, trallies, DICs, burns, head injury, overdose. What about the phases of ARDS? So ARDS has three phases. The first is an exudative phase. This occurs in the first 4 to 7 days, where there is primarily edema, interstitial and alveolar edema. All the inflammation is entering the lung. There's neutrophilic influx, cytokine production, and loss of coagulation and fibrinolytic homeostasis. Beyond 7 days, you have the proliferative phase. Now, the alveolar intimate fibrosis and proliferation of type 2 cells and fibroblasts begins. And beyond the 21 days, you have the fibrotic phase where the lung architecture is completely lost and there's extensive fibrosis. So, these are your phases of ARDS. Then comes the pathophysiology, you know. So, it begins with the increase in the permeability, because of which mechanical ventilator in itself will induce some villi. Points. Individually, these can come as a short question. Okay, so the first thing to treat ARDS is treat the underlying cause. If you're dealing with a pneumonia, give specific antibiotics, antivirals. If you're dealing with sepsis, treat the focus of your sepsis. So that is the main first and foremost thing to do in ARDS. Second, we'll discuss about the role of HFNC, NIV ventilator support. We'll discuss about the role of neuromuscular blockage, steroids, and rescue strategies such as recruitment, prone ventilation. HFOV and APRV will cover when we do mechanical ventilation, and ECMO in short, and what all is to be done with fluids, hemodynamics, and nutrition. So you mentioned, if the question is entirely on management of ARDS, these are the main headings that you will want to cover. So coming to the role of HFNC first. Now, if you see the guideline, it is mainly on acute hypoxemic respiratory failure. AHF-RF is acute hypoxemic respiratory failure. So what they say is, uh, you can use HFNC as compared to conventional oxygen therapy to reduce the risk of intubation. But there is no specific recommendation to reduce mortality. Okay. So what are the benefits of HFNC? We have seen yesterday. All of these you can elaborate. But what are the pitfalls of using HFNC in ARDS? First is the PEEP effect of HFNC, which we very much glorify. It is not consistent. It is variable and it is only modest. So in a severe case, an invasive ventilator will give you a better controlled PEEP. Second is the evidence is not very good. All the evidence come under weak recommendations. Okay. So, and you don't have any RCT comparing the role of HMNC in moderate to severe cases. Okay. Third thing is it will delay intubation. Delaying intubation will further worsen mortality. So even if you're using, we have to monitor very carefully. So how do you use HFNC and ARDS? First, this one point includes everything. Use it early in only mild to moderate cases, only if the patient is alert, protecting airway and hemodynamically stable. Okay. So the role is only when it is mild to moderate, airway is protected, and patient is hemodynamically stable. How do you start? You start at a low flow, so like a sufficient flow, sorry, 30 to 60 liters, and you titrate the FiO2 to a targeted SpO2. Once you have started, you have to monitor this patient very closely. We've already seen the monitoring parameters yesterday. And you can use subjective indexes like the heart rate, RR, use of axillary muscles, SpO2, or you use an objective index like the ROX index. And if the ROX is declining, it will predict HFNC failure. In such a case, you should always have a low threshold to escalate to either an NIV or mechanical ventilation. And for severe cases where the PF ratio is low or the patient has a high respiratory drive or evidence of multi-organ failure, directly go in for a controlled invasive ventilation. In this case, you can use HFNC only as a bridge till you actually go ahead, take consent, intubate and the patient and put them on mechanical ventilator. You can use it only as a bridge, that also under strict monitoring. What is the role of NIV in ARDS? So what does the guideline tell you? They are unable to make any recommendation of whether you should use it or not in an acute hypoxemic respiratory failure to reduce mortality or prevent intubation. So there is no specific recommendation of NIV or no specific evidence to say that NIV does reduce mortality or prevent intubation by. So we have to understand what happens when you use NIV in patients of ARDS. Okay, these in 4 points, I'll explain you what are the risks of using NIV in ARDS. The first thing is patient has a high respiratory drive. So what is happening? They're generating tidal volume. You must have seen this at the bedside. ARDS patient or any patient who has a very high respiratory drive, when you put them on NIV, sometimes even with very small pressure supports, they generate very large tidal volumes, even 700, 800 ml of tidal volume. So this we know can cause bolus trauma, especially in ARDS. We are talking about a baby lung or a heterogeneous lung where we want to give low tidal volume. So the patient's own respiratory drive plus your pressure support will cause a very high tidal volume generation. Second problem is transpulmonary pressure swings. Now to understand transpulmonary pressure swings, you have to understand this diagram, okay? So transpulmonary pressure is the difference between your alveolar pressure and your pleural pressure, okay? So when a patient, normally how much is your alveolar pressure? Or say it is almost -1. And normally your pleural pressure is around -8 over here, it's mentioned, okay? So -1 minus of -8 is almost 7. So your transpulmonary pressure is 7. So it's the difference between alveolar pressure and pleural pressure. Now, a patient who has a high respiratory drive. So now what happens is your pleural pressure goes very low as -15. And you're on top of it. Suppose you're giving a pressure support, just roughly, for example, we say you're giving a pressure support of 15 over here. So the difference between this 15 minus of -15 comes to 30. This 30 centimeter of water is high. So when we discuss TPP, when we discuss mechanical ventilation, so anything about 25 is associated with a high risk of a ventilator-induced lung injury. So this is another problem of using NIV in ARDS. The third problem is negative pressure pulmonary edema. So what do you mean by negative pressure pulmonary edema? So basically, if there is asynchrony, the patient is taking breath when the ventilator has already delivered a breath. So now he's already breathing against a closed mask. So if there is any asynchrony, what happens is the negative intrathoracic pressure generated is very high. High negative intrathoracic pressure will suck in more venous return into the right heart and into the pulmonary circulation. So more blood, the pulmonary capillary pressure will increase. But for the uh, so if this is your pulmonary capillary, your the blood, the pressure inside this is increased. But what about the pressure around it in this interstitium? That will is not is low. It is not as high. So this difference, this gradient, will cause more and more uh, extravasation of fluid into the interstitium. Okay, so again I'm explaining you this. Patient is generating a high negative intrathoracic pressure whenever there is a patient ventilator asynchrony and breathing against a closed mask. Intrathoracic pressure is high means more venous return, more blood in the pulmonary circulation, more blood in the pulmonary capillaries. The hydrostatic pressure inside the capillary is high, and negative intrathoracic pressure means the pressure outside is low. So this favors movement of blood into the interstitium. There is more pulmonary, more edema, and more dyspnea will just worsen with this. The fourth and the last mechanism of risk with of NIV with in ARDS patients is PCL or patient self-inflicted lung injury. So we know high inspiratory pressure has high transpulmonary pressure during inspiration. What happens because of this? There is a concept called as pendulum phenomenon. So there is so Alex, to understand pendulum phenomenon, try and look at this diagram. Okay, you have alveoli over here. Now this A part is what is happening in inspiration. So what happens is you are taking in ARDS, your alveoli are heterogeneous. That means the different alveoli have different time constants. Time constants is basically the time required for it to distend. Okay. So during inspiration, some alveoli have smaller time constants. That means they will distend faster. Whereas the other alveoli have lesser time constants. That means they are distending slowly. So even before the breath is completed, what happens is there is shift of air between the alveoli. The alveoli which have distended already or with a lesser time constant will shift the air into the alveoli with a higher time constant. So this shift is what is called as the pendulum phenomenon. Okay, and the exact opposite thing happens in expiration also. Okay, so before the breath is completed, only between the alveoli there is shift of air. This happens because of heterogeneity. All right, some of them having lesser time constants, some of them having higher time constants. So what is happening is there is some regional over distension. Some part we're trying to you're delivering a predefined tidal volume, but actually some of the alveoli might be getting a tidal volume much more than what you are delivering because of this pendulum phenomenon. That is why it is called occult. The tidal volume that you are seeing on the ventilator is different, and the tidal volume that actually some of the alveoli are actually receiving is different. So that is why this thing is known as an occult pendulum phenomenon. So because of this, there is redistribution and increase in the shear stress. Now, this shear stress will cause inflammation and fluid extravasation. And this extravasated fluid further will increase your lung injury, and this will further worsen your respiratory drive. So this is a concept known as PCL or patient self-inflicted lung injury. Okay, so these four mechanisms you should know of why NIV fails in ARDS. One, volutrauma because of high tidal volumes generated. Second, high transpulmonary pressure swings. Third, negative pressure pulmonary edema. And fourth, PCL. So how do you use NIV in ARDS? Only for mild to moderate. Same like HFNC, these 5 points are the same thing. Use it only in mild to moderate cases. Patient should be hemodynamically stable, able to protect airway. Okay. And always do it under monitoring. If the PF ratio is low, just avoid NIV. Directly go ahead for an invasive ventilation. So interface and setup, you should choose the best fitting mask or consider a helmet NIV if there is a good expertise. We've already discussed this yesterday. And closely look for failure. like in HFNC, na, clinic, either some clinical parameter, or over here you use your hack or score. Do you don't leave the bedside of the patient. You watch for all of this, and at any point, you should have a predefined escalation time. You should be ready for intubation in case there is any worsening, or even if the patient is not improving. So this chart sums it all. Okay, if the PF ratio is less than 300, start on HFNC. You start on HFNC. If patient is not improving after 1 hour, go ahead with NIV. If patient is not improving after 1 hour, go ahead with endotracheal intubation. At any point, if there is any of this, matlab hemodynamic instability, renal failure, reduced consciousness, or to begin with only your PF ratio is less than 130, 150, don't do any of this directly. So ventilation strategy day. So, in invasive mechanical ventilation, we do low tidal volume ventilation. This is the therapeutic strategy, one of the therapeutic strategies that has a proven mortality benefit. Mind you, in ARDS, there are a lot of studies